I'm Dr. Walter Peschel. I've practiced medicine in Missoula, Montana since 1974. My practice was composed of internal medicine, a lot of intensive care work, general surgery, and obstetrics. I've been retired for a little more than 10 years, and I've been doing some research on inflammation probably the last 20 years. I think I have a solution to the COVID crisis, which I will explain to you. Since COVID prevention with vaccines and elimination with antivirals has not yet been fully perfected, and also because of the realization that most of the risk in the sickest patients drives from the viral-induced hyperimmune response rather than from the virus itself, triggered many failed attempts to lower the mortality in COVID infections using traditional anti-inflammatories. We have two insults pushing on our mortality with this virus. One is the virus itself. That is kind of a modest intensity. And the big ones are the immune response, being much more active in the high-risk patients. Because we have failed to have any treatments on hand that get rid of those modalities of tissue injury, COVID has now risen to pandemic proportions. There may be a solution to this. Over the last 20 years, experimenting with humans and animals in approved and off-label experiments in acute and chronic illnesses, I've developed a 4-drug anti-inflammatory treatment that seems to be superior in improving adverse clinical courses in multiple diseases as compared to traditional anti-inflammatories. It works not by eliminating the pathogen, but by decreasing the percentage of the immune contribution to disease, as documented by a simultaneous lowering of the CRP, which measures the intensity of the immune response to normal or low normal levels. In a small off-label study, using a previous failed COVID-19 protocol, I simply substituted my 4-drug protocol for the single drug traditional anti-inflammatory that was used. The results were unbelievable. In both the low-risk patients, the people who are younger, 30 years of age with no chronic disease, and the high-risk patients, older patients, 60 years of age or older, with chronic diseases. The literature states that somebody in the high-risk group can expect a 50% hospitalization rate and a 30% mortality. That's what my treatment was going up against, and we've got to improve from that. Now, the sequence in infection is the virus gains entry and gets into the immune response and activates it, as documented by increasing CRP levels. And as the immune response hyperactivates, it destroys lung tissue. A normal CRP goes from 300 measured as high as 450, and normal oxygen saturation is 96, and the minute it goes down to 89, requires hospitalization or ventilatory support, and as it decreases, associates with 80% mortality. Now, here's what we got. Also, if you measure both the CRP and the oxygen levels simultaneously throughout the clinical course of the disease, and then have a treated and untreated group, you can evaluate the benefits or lack of benefits from your treatment quite easily. The literature shows in high-risk patients, a CRP starts out at 3, which is normal, and increases to 10 and up to 20 or 30, and in some cases as high as 450. Now, the associated lung damage has an O2 sat beginning at 96. It falls down to 89, requiring an admission and ventilatory support, and it can go lower and associates with the 80% mortality. The same patient treated with the Peschel 4-drug protocol did the following. CRP started at 3 and remained that throughout the entire 1-month course, with the exception of a brief reversible increase to 8.5 for a couple days in the 3rd week. The O2 sats remained normal at 96 throughout the hospital course, with the exception of a brief decrease to 93 on the 3rd week. When compared to normal levels of CRP of 3 and O2 sats of 96, this treatment has taken essentially one of the most excessive immune responses I've seen down almost to normal. It's a good chance, if treated appropriately with the Peschel protocol, these high-risk patients could emerge as an outpatient, not admitted, not dead, self-immunized, building up herd immunity inexpensively and safely. These medicines are safe. They can be administered by your own physician. I think they would mix well with whatever is being used for your COVID. Any other new vaccination or antiviral that may be developed. The cost is $3 a day, $100 for the 28 days. There's absolutely no money that goes to me on this. In fact, it's the only money goes to the pharmacist for the 4 generic medications. I would like to show you now how the normal immune system works, and show you to realize that we need a good low-level baseline immune response at all times for maintenance and repair. We don't want to disable it or eliminate it with any treatment. And then I'll show you the disease sequence, focusing on the immune response, comparing the low-risk and high-risk patient, and show you perhaps where our more powerful anti-inflammatory be working to give us these results that we're showing. Okay, this is this patient is not infected. He has no virus. His immune response is just on at idle, and he's putting out small amounts of cytokines, the little immune molecules that are necessary in small amounts but can become toxic the higher in concentration they get. They go to all tissues, and here the lung for maintenance and repair. We need that. And they also go to the liver to make this C-reactive protein that we measure that tells us the intensity of the immune response, and that level usually is 3 or less. So normally, without infection, the immune response is on at idle. It's bathing the tissues with small amounts of cytokines that are beneficial, and the amount of cytokines released is proportional to the CRP level that is normally 3 or less. Now let's infect this guy with a virus, COVID virus, and let's assume he's low risk. He's 30 years of age and he has no chronic disease. Okay? Now, the virus gains access into the body. It's attracted to the lung because the lung has these special ACE2 receptors that the virus uses for entry. And he starts to do a little bit of damage in the lung. Not much. The oxygen levels are still 96% because the lung has a lot of reserve. Now, injury molecules come out of the injured part of the lung down to the immune response. And they turn on the immune response that sends out cytokines through a switch that has low sensitivity. And they deliver a moderate amount of cytokines that go to the virus to eliminate the virus. And that's all you need to eliminate the virus. It adds a little more collateral damage to the lung. That's insult damage. Here's collateral damage. But there's still a lot of good lung tissue left. And so the O2 sat is probably still 96% or just a little bit less than that. Now this patient has got a fever, cough. He might have lost his taste and smell, but he has lots of lung tissue left. His O2 sats are still close to 96%, and he's able to survive as an outpatient until the virus is eliminated by this immune response. He repairs his lung and he's back to normal. In the meantime, the C-reactive protein is probably showing 4s and 5s, up a little bit. Varies in each patient, okay? Now, that was a low-risk patient. Let me take and give you a high-risk patient. This guy's older. He's 60, 70. He has chronic diseases. The worst ones are diabetes, but hypertension, heart disease, all those increase the risk. And he gains entry into the lung. He does it's the same virus, the same viral load. He does the same small damage to the lung. The O2 sats are still in the first week of illness, 96. He sends mediators down to the immune system. They turn on but this time they deliver the cytokines through a switch with high sensitivity. So we get a storm of cytokines, many of them. It's not any more effective in getting rid of the virus. It adds a lot more collateral damage, though, to the lung. This time. There's not much normal lung tissue left. The O2 sat drops. If it drops to 89, he's got to be admitted and requires ventilatory support. If it goes down much more, his mortality goes up. The magic number seems to be 89. If we can keep the oxygen levels above 89, they won't be admitted and they probably won't die. So look in our treatment. Can we keep the O2 sats above 89? These excessive amount of cytokines, the storm has went to the liver, and you have 30 to 400 level cytokine. The difference between the low risk and high risk is the sensitivity of the switch. I think my treatment will lower an elevated sensitivity, whereas traditional anti-inflammatories won't. The difference, I think, between the low-risk patient and the high-risk patient is the degree of switch sensitivity. I think young people who don't have chronic disease haven't moved that switch around and used it enough to activate their immune responses, so the sensitivity is low. The same dose of virus will give a lower amount of cytokines than the older high-risk guy who already has chronic diseases, because he's had that switch on most of the time of his life, and it moves easier and faster. I think the same viral dose up against that switch will give much more cytokines and much more collateral damage. I think our treatment lowers switch sensitivity, whereas traditional treatment doesn't. And that's where I think we are getting the results we are. Now, I want to show you a little bit about how we did the experiment. Now, as I've told you, and here's what I see that's not done right in a lot of these scientific papers, is they don't realize maybe that the low-risk patient is going to respond with much less cytokine and much less collateral damage and mortality than the high-risk patient. So if you have a 10% low risk and 90% high risk versus having a 10% high risk and a 90% low risk, you're going to get a whole lot of different answers and not have as good of evaluation of your treatment. You've got to separate the low risk group in the low risk and the high risk group in the high risk, and then randomly divide them into a treated and untreated group and compare the treated untreated group within each group separately to each other, the low risk and the high risk. And then I think you get some meaningful data as far as benefit with your treatment in each group. Okay, so here's the mix of total COVID patients walking around. And we pull them in from the lab, and we non-arbitrarily separate them out by risk, low risk and high risk. Once we've done that, we arbitrarily divide them into treated and untreated groups in each the low risk and high risk. And then we can compare the treated group to the untreated group. Okay? And what we kind of find is the low risk groups are pretty easy. You know, most of those people without our treatment will survive as an outpatient. 3% will die, get sick and die. The treated group, the treated person we had stayed completely normal. His CRPs are below normal. His O2 sats are entirely normal the entire course. Clinically had like a 4-day case of the flu, recovered quite rapidly, wasn't admitted, didn't die, went back to work in about 8-9 days. Okay, I think that we should treat the low risk group because, like I say, 3% can break off and get real sick and die, and we may prevent that. Plus, I think that it seemed like they get through the illness a little easier. The high risk group is a little more exciting. Here's the untreated one. C-reactive proteins, 3, 4, 40, maybe 400. Oxygen levels, 96, 93, 89, ventilator, admission, 70, death. The same guy, the same risk patient, now with our protocol, and these are our results, done at St. Pat's Hospital, C-reactive protein stayed almost normal to 3, and a brief increase to 8.5 for just a day or two in the 3rd week, along with a normal O2 sat with a brief dip to 93, which recovered in the 3rd week. There's not much damage here. This is not anywhere near 89. 89 is the number where they get admitted and get in the ventilator. And we're a long way from 89. Now here's normal. I show you normal. I'm going to show you normal to compare with the high risk not treated and the high risk treated. Their CRPs are less than 3. Their O2 sats are 96. Boy, that is pretty close to this. just a little change here. That makes me think if we could take this where 50% are admitted and 30% die down to here, none are going to be admitted and none are going to be die. 89 is the number that gets you admitted. We're a long way from 89. We got lots of extra room there. So let's compare these three patients. This is the high risk not treated. His CRP goes up. And at the same time, his O2 sats go down. Right here is admission to the hospital, and here's death. Okay? Here's the treated guy. He does pretty good. He's got that little blip. Not anywhere where you need admission. This patient did not die and wasn't admitted. Here's normal. This is awful lot just like this. I think if we can get these patients on this protocol soon enough after getting their diagnosis, we can keep these patients more like this, and they will emerge from an outpatient illness like the flu, self-immunized, acquiring herd immunity that will prevent future infections, eat more easily and more safely. If you've got to go through this and try and survive and get herd immunity, that's a lot more riskier and more expensive than to go through this and get it. These medicines are all safe. They can be given today by your own physician, off-label. They will mix. I think you have to check with the hospital computer for each patient. I think they will. These medicines will mix whatever there could be treated for COVID, like remdesivir. Again, the cost is low, $3 a day, $100 for a course. I think this treatment could resolve our economic problems and lifestyle and life expectancy problems right now. We don't have to prevent that virus. We have to just keep it from making us sick.